Usain Bolt, while running, at the end of his run, his tibia went into a lot of external rotation and femur rotated internally. And because of that, he has injured his hamstring muscle while running. In remodeling phase, load hamstring eccentrically and Nordic progression exercise is a gold standard.
Ambiguity and result needs quantification.
Fitmus device will definitely gonna help us because it gives us a digital figure. 5 kgf distance is there.
Aspeter's hamstring injury protocol, the mid-range eccentric muscle strength testing with your Fitmus device is actually the gold standard when it comes to criteria-based rehabilitation. Good afternoon, everybody, and thank you so much for attending this workshop. I'm very sure you're going to be excited about meeting the keynote speaker for today. That's Dr. Sagar Mahajan, because he'll be sharing some of his very interesting, latest research findings and the protocols and the results that he's been obtaining out of those protocols and rehabilitation, treatment journeys, specifically for hamstring injury rehabilitation. So basically, just want to give you a quick background about myself. I'm Anmol Saxena. I'm the founder and CEO of Ashwa Tech. And my journey actually started in this domain of physiotherapy technologies almost in 2007 when my mother got a right ACL tear. After that, in a couple of years, due to her postpartum complications, she was suffering from lower back pain and spinal problems. Recently, like around 7 years ago, she was diagnosed with osteoarthritis in both her knees. And now she was also diagnosed again another 3 years before she was diagnosed with osteoporosis actually. But it is the miracle and grace and the hard work of a lot of physiotherapists like you guys who are participating today, who have actually helped my mother overcome and manage all those injuries over the years. And in fact, today she's aging stronger than ever. She's not just doing all her daily activities, she's actually very active. She's been doing a lot more than she could do that 10-15 years ago. And that is the reason why I got so motivated to come and do my bit for the domain of physiotherapy by inventing some technologies. So I quit my job at Ford Motors Company and started Ashwa Tech. And we've actually built two products. Both are our patented products in India. One is FitMust. I think a lot of you are already who are participating here. If I can see the participants clearly, a lot of you are already using FitMust or FitKnees or both. So FitMust is our digital dynamometer. It assesses the strength and gives you a progress of how your patient is improving in terms of muscle strength week over week. FitKnees is a motion wearable sensor system which allows you to track the range of motion, balance, gait analysis, squat analysis, and everything that is necessary for post-arthroscopy and arthroplasty patients and also patients in conservative knee treatment. Now, we are today going to talk about hamstring injuries, and the reason why we are here, and I think a lot of you are actually looking forward to this topic in particular, is because hamstring strain injuries are so common in athletes, especially who are into running, which is almost a lot of sports. Anybody who's sprinting or who's playing football and has to run or sprint, it also goes for the same, for cricketers. Basketball players are very susceptible to HSI injuries. You have marathon runners now. A lot of our a lot of recreational athletes are now doing and half marathons as well. It's a popular sport. Now, HSI injuries do contribute to 12 to 60% of these sports injuries, depending on the kind of sport and the nature of the movements, right? The main problem that a lot of physiotherapists face in the domain of HSI is that the recurrence rate is still too high. It is 30 to 35%, even after a really good rehab protocol. So a lot like what we have heard in the field is, even though the rehab protocol was very solid, there is still something which is lacking. And that something is the criteria to allow your patient to progress from, let's say, phase 1 acute phase to the subacute phase to remodeling phase to return to sport. That is why we have invited and we are honored to have Dr. Sagar Mahajan, who will be very simply breaking down the criterias and allowing you to learn and adapt to these practices, hopefully within today's evening OPD. As you leave from this webinar and start your OPDs at 4 p.m., we hope that you are able to take away a lot of these learnings and start the implementation today. Now, what happens is within HSI domain, a lot of your equipment that allows you to quantify this criteria that you will be learning today is these very specific devices like nod boards are there, isokinetic dynamometers are there. These technologies are clinically proven as gold standards, of course, but they are rather big and expensive. And for you to do that particular assessment, it would take anywhere from 45 minutes to 2 hours. So in a clinic that sees 40 to 100 patients a day, it is practically impossible to incorporate such extensive technologies, right? The only other alternative that we have is you do everything manual assessment, and you even do the documentation manually. Now, because of that manual assessments, if one physio feels that my patient is strong enough to go to the next phase, the other physio might be a bit more conservative and feel that no, let me give this phase, the previous phase, 2 more weeks of rehab and then take the patient. In some cases that could cost the patient a little heavily, right? It could cost the patient a season or some opportunity at a game that could take them ahead in their career. So that ambiguity in result needs some kind of quantification. And if we could have some way of very simply quantifying the hamstring capacity, if we could also track how the progress is happening week over week in some very simple setup which could take a few minutes and it could be digitized, I think what you all will start seeing is, if physiotherapist A says that we should be going for the next phase of physiotherapy, now we should be starting the next phase of rehab protocol, physiotherapy B will also concur, and there will be a more synergistic approach and more standardization of the progress. So if any of you here are already running your clinics and you have FitMust, I would love to also share at the end of this webinar how you can actually use FitMust specifically for HSI. It does come with its own limitations, so you have to use it with precaution. But what FitMust can really do for HSI patients is, first, it can really simplify and quantify your progress tracking, right? So whether you're trying to compare the muscle strength of injured versus non-injured limb, whether you're trying to see your medial and lateral hamstring balance, because patients with tibial rotation problem or foot problems might have an hamstring imbalance, right? Whether you're trying to see how the strength is developing over a period of time, and whether you're also, of course, trying to see in context to your running criteria, what is the hamstring to quadriceps ratio? Because again, here we are talking about your recreational athletes, not your elite athletes. So recreational athletes might have less than 0.7 hamstring to quads ratio, and FitMust can really very quickly ease, within a matter of seconds, give you all of this data and comparison. With that, the kind of decision making you can do can be very quick, right? And with this, I would love to explain a little more in detail exactly how you can clinically incorporate FitMust after Dr. Sagar has explained how the HSI protocol should run. So I would love to invite now Dr. Sagar Mahajan to give you a quick breakthrough of this entire protocol and the latest strategies that he has uncovered. He's, of course, an MSK and sports specialist based out of Nine Pearls Hospital, Nashik. He's been a physiotherapist for 20 plus years, but beyond that, he has, specialized in DNS. He has specialized in your McKinsey protocols, neurodynamics. He's been awarded by IAP Significant Achievement Award. He is also the founder and president of Nashik Physiotherapists Association and convener for IAP Nashik branch. But above everything, he's a teacher. And he's a very lifelong learner, because the enthusiasm and passion with which he has done research for this webinar was something that we really learned from and got motivated by. So, Dr. Sagar, it's such an honor to have you here. I'll give this floor back over to you now.
Thank you, ma'am. Thank you for this wonderful introduction, ma'am. Yes, good afternoon, all. As Anmol ma'am have, she has introduced me already. so I'll not go in much detail of my further introduction. We'll straight away move into the topic like object like hamstring strain injuries. Basically, yes, for today, our learning objectives will be understanding how hamstring injury mechanism goes, and classify hamstring injuries. Like by the end of this lecture, we should classify which type of injury we have in front of us. Perform systematic assessment. This is very important because that will lead us to the classification also, and that will help us in the rehabilitation also. And yes, of course, apply phase-wise rehabilitation. That is very important because if we are starting in subacute phase and treating patient with acute treatment, so that will not gonna work for the patient. So we have to be very precise in what phase we are rehabilitating the patient. And yes, this is the last point is very important. Like decide return to play criteria, because most of the time what happens, many athletes, they come to us, we rehabilitate them, we like 1 or 2 months they are with us, and with without assessing return to play criteria, if we allow them to play, because they like nowadays, I have seen this in many times in my OPD, like patients are coming and they have the competition is very high nowadays, so they are into rush to return to the sports again. So if a injured athlete uh, wants to return to sports with his terms, then there is some concern, because if we send them to the field very early, there are good amount of chances of re-injuries, and in hamstring injuries, it is very common. It is commonly re-injured. Like I have seen many cases in my clinic, uh, like if the patient goes without complete rehab to the sports, he gets re-injured again. So these are our objectives for today. And first, we have to go before we proceed towards topic, we will go to the basics of the things, like hamstring anatomy. Like if you all you all are aware of, hamstring is made up of three major muscles, bicep femoris, semimembranosus, and semitendinosus. All these three muscles are they starts from ischial tuberosity, and they, as ma'am told, there are two zones of hamstring, medial hamstring and lateral hamstring. Like middle hamstring comprises of semimembranosus and semitendinosus, which inserts on tibia. The semitendinosus inserts with pes sensorin, and the bicep femoris inserts on the head of the fibula. So there are two bicep femoris has two heads, long head and short head. The short head, in short head, the tendon is longer inside in length, and the main function of hamstring is hip extension and knee flexion. As you all know, as it originates from ischial tuberosity, the hamstring controls pelvic motions also, anterior and posterior pelvic tilt. Mostly, hamstring concentrically controls the posterior pelvic tilt. I'll explain this mechanics in further in next to it. Yes. So the mechanism of injury, yes, mostly the injury to the hamstring muscle occurs in the late swing phase, as you all know. When it occurs in late swing phase, basically it is towards muscular tendinous junction is the most injurable site. The like if you have seen, if you have gone through the video, you will come to know that they say video is of Thierry Henry, and the moment he changes his angle of running, he had severe pain in his hamstring, and there are good amount of chances he might have injured his hamstring only. The second thing is basically the second video is about fatigue hamstring injury. Like this is you very well known personality in sports. Mr. Usain Bolt, and he, while running, at the end of his run, his tibia went into a lot of external rotation and femur rotated internally, and because of that, he has injured his hamstring muscle while running. So these are the common injury patterns which we find in athletes. So while taking history, like I will mention in my further slide, like while taking history, we should always look for a mechanism of injury. And it is like in which sports it is common. It is common in cricket. It is common in football. It is common in Australian football. It is common in ice hockey, where it is common with athletes. So all sports, running sports, you may get hamstring injury. Now I have mentioned here only two types of injury. There is one more injury called as close chain hamstring injury. In that loading in loading, hamstring gets injured, and in loading, if hamstring injures, it injures towards the insertion, like it is not injures towards the origin. I'll elaborate it on in later. Next, please. Yes. So classification of hamstring injury is like there are three grades. One is mild strain, like as I've mentioned, musculotendinous junction is the most injured site. So when the injury is in late swing phase, it injures near its origin, and when injury is in close chain, it injures near its insertion. So both musculotendinous junctions are at risk for this injury. So yes, we need to categorize the grade of injury. The grade one is mild strain, in which we can say 25 to 30% muscle fibers are torn off, and grade 2 is partial tear. In this, almost 50% muscle fibers are tear off. And grade 3 is complete avulsion, basically complete rupture or avulsion. Avulsion, there are I have seen one avulsion case with axial from axial tuberosity, and for that, of course, surgery is the treatment. uh, Next slide, please. In assessment, yes, as I have mentioned, we need to assess first. First thing we need to take in history is mechanism of injury. So in what phase of sport the injury has occurred? It was between acceleration and deceleration, or while changing the angle, as the video was as it has shown in that video, or it is at the end of the game, like it is near to the end of the game, like it is whether it is fatigue injury or not. So that is that will give us a complete idea about whether it is 100% hamstring or any other associated injury is there with it. And what all are the signs and symptoms we should look for? We should ask the patient like what you feel after the injury. So he may complain sudden pop-up sound in his muscle, and sharp pain at the site of at the site of injury. And basically, and after that also, like if we go further in that, how like could you able to walk after that? The next question should be. So he may say that no, it was difficult for me to put load on it, and it was I just wanted to keep it in a hanging, and I couldn't able to put load on my that injured leg. So that clicks, that should click us. It might be a hamstring injury. So, and one more thing, one more history we should take is, previously, do you have any injury, similar type of injury, like similar hamstring injury? Because as I have mentioned that there is a good amount of chances hamstring gets re-injured. So these four history points should be must in our assessment. Um, yes. So in history taking, we have seen an observation and palpation. Like in like when we see the area, we may we may see that the bruising all around the area, and severe sharp pain over it. And definitely patient the gait pattern is altered. See, the patient is not willing to put weight on the, as video is showing, patient is not willing, it is because of pain he is not putting weight on that leg. So that is the clear cut sign that he might have injured his hamstring. And on palpation, yes, definitely, if you palpate that area, there is a thick band you can feel. And if it is grade 1 or grade 2 injury, there is like a lot of swelling and edema has to be there around that area. So, and if it is a clear, like a complete injury, your finger may go in, as it have shown in the figure. The last thing, yeah, palpation, palpable gap. You can feel that palpable gap in between those two, torn fiber things. Next, yeah. In range of motion assessment, yes, we need to assess range of motion. If as you all know, this is hamstring is a contractile structure, and if patient complains pain in while contracting the muscle, there are good amount of chances of injury to the contractile muscle. And we definitely we have to rule out contractile and non-contractile structures, injured structures by assessing range of motion. And yes, passive range of motion, passive straight leg raise will definitely gonna increase pain. These are like why we have to be very precautious while assessing passive range of motion, because in acute phase or in partial tear injuries, if we start immediately assessing range of motion, we may injure it more. So we have to be precautious here. Just we need to assess, go beyond the range till of the patient. Like patient is taking bending his knee to 45 degree, till 45 degree, and if we press it above that and patient complains pain, we need to stop there. We don't have to push him to reach to the full range, because there are good amount of chances of complete injury if we push ahead. Yes, yeah, fit must device will definitely gonna help us in quantifying the strength what patient what our patient is having. So there are three. We should assess his strength in three angles, basically 0 degree. And fitness device is definitely helpful, because since 1 year I'm using this, and this gives us a complete objective outcome measure. Like we can use it as objective outcome measure, because it gives us a figure, a digital figure, like 5 kgf resistance is there. So we can note it down, and we can compare, we can reassess it before return to sports, and we can compare initial and after, and that will give confidence to the patient also. So majorly in hamstring injury, we assess the strength, isometric muscle strength of hamstring in three angles. In 0 degree, like you can use the strap. With that strap, you can use this fitness device. And if you don't have strap, you can straight away put device and tell patient to apply force on it. You can assess similarly. You can assess it with 45-degree angle and 90-degree angle. So the most reliable measurement out of these three is 45-degree angle measurement, because that is some research has given support to this 45-degree angle hamstring strength assessment. Yes, next. Special test, I avoid going for special test, because while assessing special test, there are good amount of, because if patient is coming in acute phase to you, it is difficult to assess special test, because all movements will be painful for the patient. So yes, I have mentioned few special tests, but it is not always like patient will come to you in acute phase. Patient may come to you in the chronic phase also. So at that time, you can assess this with this special test. Bent knee stress test is the gold standard, in which your patient is lying in supine lying. His hip is 90-degree flexed,
and we have to extend his knee passively, so that like if patient complains pain in his hamstring, then the test is positive. Modified Thomas test is also we can assess for hamstring injuries, and active hamstring test in it is like the same, but only thing is this whole test is performed by patient himself. We don't need therapist in this test, but gold standard is bending stress test. I assess my patients with bending stress test. Next. Yeah. So now we have made our mind for the patient has hamstring injury, and how we should plan our rehabilitation plan. So how should be our rehabilitation plan? The rehabilitation principles will be like early control loading, yes, pain guided progression, eccentric strengthening focus. This is very important. We most of us we forget to give eccentric strengthening, and if we don't give eccentric strengthening to the patient, there are good amount of chances of free injury. And core and pelvic stability. Yes, these two factors are very important in hamstring injury rehabilitation. Basically, if your core muscles are weak, your pelvic control is not not proper, and because of that, there are chances of hamstring injury again. So core muscle stability is like we should work for, and of course, if we work on core, pelvic stability will come for sure. Yes, in acute phase are as you know that initial 48 to 72 hours, this we have to go with the price protocol, like pressure or police protocol, you can say, like police principle, like pressure, optimum loading, very optimum loading, like complete bed rest also is advisable in this case. Icing, to reduce inflammation, we need to give icing to the patient, because every 2 hourly icing will reduce inflammation on that area, and it will help in reducing pain also. Then compression, yes, there some kind of like prep bandage or anything like that, or RJ you can use for compression of the hamstring muscle, so that inflammation or swelling will not increase. And elevation for sure, whatever swelling has occurred, we have if we keep it elevated, the swelling will go down. This police principle will last, as far as my experience is concerned, 0 to 72 hours. We have to follow this police principle. 0 to 72 hours, we don't have to give anything any modality or any mobilization or anything to the patient. Let that injury get settled on its own. After that, yeah, if patient complains pain, then we should plan giving some pain relieving modality to the patient, like ultrasound therapy. You can use any modality nowadays. A lot of options are available for pain relief. Like for me, I go with ultrasound more. You can try out laser for removing lactic acid accumulation, or accumulated lactic acid removal. You can use laser also. You can use interferential current therapy for pain relief and edema reduction. You can use stents for pain relief. You can use PEMF. You can use all sort of modality, whatever options you have for pain and inflammation control. After with this pain and inflammation control, we should go with some gentle isometric hamstring strengthening, because it will maintain the muscle strength. Like if it is a partial tear, if you are using isometrics in early phase, it will help us in rehabilitating patient in later phases when we go for concentric and eccentric training. Of course, pain-free range of motion also we should advise, like whatever that will not it will help in reducing joint stiffness, other joint stiffness too. So available range of motion, available pain-free available range of motion, we should give range of motion exercises to the patient. So this acute phase will continue, as far as my knowledge is concerned, it will continue to 0 to 2 weeks. So in these 2 weeks, if we succeed in reducing pain and inflammation and gain as much as range as possible, then we should move towards next phase of rehabilitation, that is our subacute. Okay, sorry. With this, we can also use taping, as I have mentioned. If injury is at the um, like where your injury is, your taping should be your taping principle should go accordingly. So yes, we are using Y shape kinesio tape here. Here I am fixing insertional end because in this patient, insertional hamstring injury is musculotendinous hamstring injury is there, and this tape will, like, we will fix up the anchor at insertion with 25% stretch. We can take it to the origin site. If your site of injury is towards ischial tuberosity, your anchor should be at ischial tuberosity, and we should apply uh, um, uh, to approximate muscle fibers this cross taping on it, and it will help in protecting your hamstring muscle, and it will relax, and it will help in healing also. So in acute phase, you can use taping, and you can use it twice or thrice in a week, taping, and tell patient to maintain it forever, like for these 2 weeks at least. Next. In subacute phase, yes, have to, like, what you should, like, active hamstring curl ups we should start with, like full range of motion active hamstring curls. We can start. We can start active hamstring raise exercise. We can start bridging. We can start plank. In plank, there is a slight amount of eccentric loading on hamstring. So we can just start eccentric loading in subacute phase at the end of subacute phase, and concentric contraction of hamstring. Yes. Next, in remodeling phase, yes, once our this concentric contraction, in that you can use weight cups, also weight cups, hamstring strengthening. You can use therabands. You can use everything in subacute phase. But in remodeling, we should think of giving rehabilitating patient through eccentric training, like eccentric loading, like eccentric strengthening of hamstring muscle. That will help the patient to load hamstring eccentrically, and it will prevent a lot of further hamstring injury. One gold standard exercise every for hamstring rehabilitation is Nordic progression exercise. In this, patient is in kneel standing, and therapist is stabilizing his both feet, and patient try to bend forward and extend it from his knee. So that will put a eccentric load on hamstring, and that will help in basically training of your hamstring muscle. The more you bend forward, the more strain will come on your hamstring. So it should do it in a progression. You can hold that position for 10 to 15 seconds and then come back to the starting position. So this Nordic progression exercise is a gold standard. You need to teach this exercise very, to the athlete, because he needs to do this for longer time, longer time. And yes, Romanian deadlifts and lunges has to be the part. Like, there are a lot of exercises you can design for your athlete, so that he will do all those exercises for his, throughout more time. Yes, in last phase of our rehabilitation, this is functional phase, that we can call it as return to sport. In this, you should start with slow progression jogging exercise, with after that sprint progression, like patient can go for sprinting also. And agility drills, you with the help of cones and this thing, you can tell patient to figure of eight running, and and crossing the cone, and with stipulated time, we can and these agility drills, you need to design it like you can take it at on ground also. Yes, this plyometrics, box jumping exercises will definitely help in rehabilitating hamstring muscle. And the last thing is sport specific training. Like if he's a footballer, we should tell him to go for slow drills, like football dribbling and all in practice. So that will help him in before return to sport. Return to play criteria, like as we have seen earlier, what patient should have before he returns to sport, pain-free range of motion. Of course, this should be the first thing. Second, most important thing is 90 to 95% strength of opposite side. Here again, fitness device will be more helpful, because previously we have assessed hamstring strength. We can compare that strength with post post rehabilitation hamstring strength. So that will give us idea how much hamstring strength has progressed in our with our rehab. And after that also, we can compare the strength of hamstring with the normal side. If it is the hamstring strength of affected side is 90 to 95% of the normal side, then we can say that this this athlete is ready to return on sport. And the next criteria has to be pain-free maximal sprinting. Yes, as I have said, like we have seen that the hamstring gets injured in sprinting, and mostly in late phases of sprinting where fatigue is there. So sprinting for 100 meters with stipulated time, if he could able to do, then we can tag him as a like a, you can return to sports. And yes, of course, athletes psychological readiness, because most of the patient, we need to do a lot of counseling to the patient with our rehab, because if with this counseling we can help him in we can motivate him, like you can play a game by giving simple examples, like hota hai, you can it is just a matter of time, you're gonna come back on and perform well. So that sort of instructions if you're giving, and you keep on motivating him, and you have to keep his you have to keep him motivational all the time, so that while return to sports, he will be more energetic, and there will not be any hesitation in his mind that my hamstring will get injured. So that confidence we need to give it to the patient. So that is very important. And with this, there are few red flags I need to mention over here. Basically, where we should take for not every hamstring sprains we can treat. There are some red flags to it. So severe pain with difficulty in walking uh, is a red flag. There are good amount of chances that hamstring is completely teared off, and in complete tear we have very limited role to play. We have role to play post surgically, but if it is a complete tear, ultimately he needs to go for an investigation. Ultrasound and MRI are the choice of investigation after if you are suspecting hamstring complete injury. Ultrasound will give us an idea about how much tear is there or any avulsion is there, and even MRI is also conclusive. Yes, large palpable muscle gap also indicates complete tear, and again, so the suspected avulsion injury, of course, yes, we need to confirm it with MRI only, and referred the patient to the orthopedician. Orthopedician will definitely that is his case. It is not our case. So we need to differentiate where we have to go for this treatment, and where to refer the patient to the orthopedician. So yes, and basically for recurrence prevention, what as I have mentioned, what athlete has to continue for long time. There is regular eccentric training, Nordic exercise. He has to continue for longer time. Core and pelvic stability. Yes, uh, if you are assessing athlete before sports or before injury, what in hamstring injury per se, what you should assess? You should assess the hip flexor tightness, hamstring tightness, and core muscle strength. So if these three components are present in an athlete, so there are good amount of chances of him to get injury and get injured with hamstring muscle. So yes, core and pelvic stability exercises for recurrence prevention. He has to continue for a long time. If you know that patient has hip flexor tightness, so hip flexor stretching exercise has to be given to the patient. If you know that hamstring tightness is there, after complete rehabilitation, you should teach patient hamstring stretching exercise so that the hamstring muscle flexibility will increase. And of course, load management we need to teach patient. And before play, the athlete should do proper warm up because without warm up, chances of injury is very high. So this is about it. And the take the key take home messages are hamstring injuries are eccentric load injuries. So you need to keep it in mind whenever a patient comes to you. You need to ask mechanism of injury, and if video is available, if you need to see that video, and then make your mind that this might be a hamstring injury. The most important thing is Nordic exercises reduce recurrence. That is very important because like you need to teach it very nicely to the patient so that he will do it for longer time. Third key takeaway home message is early control rehab improves outcome. Definitely, the early you start, the better is the outcome. And return to sport should be criteria based. If any of your criteria is not fulfilling, you should tell the athletes don't return. You may get injured again. Don't hesitate in giving your opinion in any platform. I remember one of the incidents. I just have to share it with you. One athlete came to me with similar hamstring injuries, and after 1.5 month of like he approached me, and after 1.5 month of that, he was having one national event, and he was selected for that, and he wanted to play for that event. So I told him I'm not very sure that whether you will be able to play it or not, but yes, we will go with your rehab, and we'll take the decision at the end of one first month. So we have started his treatment, and after 10 or 15, 10 or 12 sessions, his pain was disappeared, and I have started rehabilitating him. He was not able to perform eccentric strengthening without pain um, by the end of 1.5 months. So I advised him, you don't go basically, but it was his lifetime opportunity, so he didn't want to miss that, and he said, "Sir, while running, I don't have any pain. I want to go for this because I don't know whether I'll get another chance or not." So he went for that sport, and I think in third game he injured his hamstring again. So that's why. And then he came back to me again, and I told him that, see, I told you your rehab is not was not completed. So with half rehab you went and you got re-injured. Now, now what? So again we have to start his rehab again and do everything again. But the lesson for him or me was like there is we should not be in hurry to send the athlete to the sport back again. proper our criteria should be fulfilled, then only we should advise them to go for sports. Otherwise, there are chances of more injury than previous in like in future. So these are the takeaway message. I'll hand it over to Anmol ma'am for next, and after that we'll take question and answers.
Thank you so much, Sagar sir. I think even I learned a lot, and I'm very sure all the participants here must have learned and from your experience and from all the research that you've put into the to creating this protocol and testing it out with thousands of patients every day, right? So, for all the participants, whoever are attending here, I am very sure you're very keen on asking a lot of questions to Sagar sir. So if you haven't put your questions or your queries, if any doubt, any patient cases you want to discuss with Sagar sir, this is going to be another 2 minutes and then we will be opening the floor. Meanwhile, please do put your questions in our chat box also. I hope my team has kept the chat box open. So please put your questions. We'll try to take as many as possible. Okay. Now that you have already learned about the various phases and the criteria to proceed to the next phase, how you can actually use your fitness tool for your patients, like Dr. Sagar has already mentioned. It is an aspetos hamstring injury protocol validated over not just elite footballers in Britain, but also over recreational athletes. The mid-range eccentric muscle strength testing with your fitness device is actually, which with any handheld dynamometer for that matter, is actually the gold standard when it comes to criteria based rehabilitation for your hamstring. But in 90-degree, the hamstring is in a very advantageous position. So you will get a very strong, high amount of force. The maximum force that the hamstring will produce and give you will be at knee bent at 90-degree. However, if you want to put it to the most disadvantageous position, you have to lock the knee at 0 degree and then put the fitness device, like Sagar sir said, with a belt, or you can just counter force it. One small trick that I would like to share with all our existing customer is, you are dealing with obviously athletes. Their stronger side could be stronger than you, and in that 45-degree position it might be difficult for you to actually allow them to push against, and you will break the test. So that is called make test. The patient is making the force, right? What you can actually do, and it is as clinically valid and reliable as the make test, is the break test. What you do is ask your patient to lie down at 45, lie down in prone. The first, the non-injured knee should be bent at 45-degree. You put the force and ask them to hold. So you are putting the foot mask and you are asking, you are the one putting the force. Ask them to keep holding until they break. Okay. When they break, you take that as the peak force. That after this force, they are not able to take the applied force. Okay. So it is also as valid. It is 97% correlated to your make test. You can use a break test when you're using in handheld. And even the intra-examiner reliability is as high as 94%. Please make note that inter-examiner reliability is not as high, which means if you examine the patient the first day, after 5 days, 15 days, when you reassess the patient, you only have to reassess it. Please do not ask another physio to reassess the patient. The data will be invalid. Okay. Now, that being said, there are some very latest research where, as you can see, doctor is using the fitness to test the medial and lateral hamstring balance. So like you saw in Usain Bolt's video, right? Due to fatigue, the tibia had rotated externally, and then the pelvic angle had shifted, and that is where the injury occurred. What you can do is, throughout the journey of the patient's rehab, along with the 45-degree your hamstring left versus right or injured versus uninjured symmetry that you will be tracking from fitness, you can actually in that you can put the knee to 90-degree, the uninjured, starting with uninjured hamstring, laterally rotate the tibia, and then take the force. So you will get the medial hamstring. Medial hamstring means semimembrosis, semitendinosus, muscle strength, right? And then you once again put it in lateral, you medially rotated the tibia, and now you will get the lateral, which is your bicep femoris hamstring strength. So you will get 1 M is to L ratio. take it on the non-injured side, then again take it on the injured side. Compare it. Actually, one of your RTP criteria should be that your MS2L, medial to lateral hamstring balance, should be the same on both the sides, at least within 90% accuracy. So while there is no one fixed number, like hamstring to quadricep ratio should be above 0.7, so that the acceleration deceleration is controlled. For MS2L, there is no clear balance yet. There is no ample research with basically digital isometric dynamometers, but relativity is very strongly correlated with the risk of re-injury or risk of injury of hamstring strength. So I hope if you have any queries, I hope this was a little clear. Mainly two ways that we would propose you use your FitMust. You use it at 45-degree, left versus right limb symmetry, track the progress of that. And then you use lateral and medial hamstring, take the MS to L ratio on the non-injured and injured side, track the progress of that. Okay. So if you have any other questions, again, now is the best time to ask those questions. Our hope with this webinar was to share that knowledge of one of the most well-established physiotherapists in the domain, get his protocol and simplified, break it down for all of you, so that not now all of you can actually start using this protocol, using the criteria, and establish yourself as hamstring injury super specialists, as well as tech enabled and tech driven physiotherapy centers with FitMust, as well as this latest hamstring. So if you have any further questions or queries for Dr. Sagar or the application of FitMust, please, now is the time. We have, I believe, another 5 to 7 minutes before most of your OBDs start at 4 p.m. So please take the opportunity. Even after the webinar, we will be giving you a condensed flow chart of the entire presentation, so that it is a takeaway from our side to you, so that you can take this and start using it, start practicing it in your clinic very easily. So that flow chart will come to you in a couple of days' time. Also, if you have any kind of specific topic that you have in mind, or you have something to add or give any feedback to us, please scan the QR code. If you want any specific train or any specific topic, we can try and make that happen for you next. As you all know, last time we have done a webinar with Dr. Abhivakti Navgeet on rotator cuff and ACL. Very soon we'll be coming up with a new one. This, of course, has been an amazing learning journey with Dr. Sagar Mahajan on hamstring injuries. So now I'll open the floor. Are there any questions on the chat bot? Otherwise, please raise your hand. We can ask you to unmute yourself and raise your question. Any particular question? So there is, I think, Shalvi Poralkar, doctor. She's asked any safe eccentric hamstring exercise to start in acute subacute phase for rehabilitation.
Yes, actually, we can basically not in acute phase. We cannot start eccentric training in acute phase because chances are like if we start eccentric training in that phase, there are good amount of chances of recurrence again. So yeah, for in subacute phase, you can go for rehabilitation with weight cuff, and in that weight cuff you can go with offloading eccentric training with minimal weight, or with therapist resistance. So that way we can do, but active eccentric exercise is not recommended in this case, because the injury is not completely healed yet, and it is in healing process we apply stress on the injured area, there are chances of re-injury again. So be very cautious in giving eccentric training in subacute phase 2. Basically, uh, it will increase the risk of re-injury.
Thank you. So I hope, Dr. Salvi, that answered your question. Dr. Arthi is asking, in what protocol do we train hamstring muscles post TKR, post 6 weeks?
Yeah, in hamstring, like post 6 weeks, post TKR, we can go with concentric hamstring training with resistance training. like with tubing, TheraBand, or any like if anybody is um, increasing in weight, calculating 10 RM of the patient, and then going for hamstring strengthening after that. But in TKR, mostly TKR patients are older patients. So, like my observation for TKR patients are like, if we go too aggressive with them, like with this TheraBand and TheraTube, there are good amount of chances they don't have that capacity first of all to do these exercises. So we prefer going slow with them. We start with half kg weight and we progress it to 1 kg or 1.5 kg. That's it. We cannot go beyond that. And that also with precaution. If with the repetition, patient complaints increase in pain, we reduce the repetitions. But if patient is comfortable, then only we progress. So hamstring strengthening, yeah, prone knee bending exercise we can start off. We can start like wall squats, partial wall squats. Also, we can start partial wall squats. It's for quadriceps though. Yes, we can start stair climbing training, which has already started before 6 weeks also. Many surgeons they prefer after loading like close chain training after 6 weeks. In that you can start stair climbing, squatting, or forward lunges. You can start that. So that way you can train a hamstring.
Thank you, sir. Dr. Ati, I hope that answered your question. So another question from Dr. Jayani. What protocol do you normally follow for hamstring injuries? Could you give us a reference as well?
Yes, ma'am. There is one journal. That's what I was like. There is a journal named Journal of Athlete, and in that, if you there is one article named hamstring strain injury rehabilitation, and the protocol has been taken out from that. And there are many articles. I'll share those articles with you I'll with reference. I'll share those. I'll request Anmol ma'am to forward it to you with mail or through mail. So we have a reference for this. I'll forward you those references.
Right, sir. And Dr. Richika is asking, how can you decide if the patient has come to phase 3?
Yeah, in phase three, patients mostly they don't complain. Their primary complaint is not pain. Their primary complaint is while doing some activity, like while doing their while running, while doing activity, they complain pain. So that is the sign, patient is in came to you in third phase, and in that, see, all those you need to check range of motion. If full range of motion is there, you need to palpate the area. If pain on palpation is there, then you can confirm that yes, on palpation pain is there. So yes, there is some kind of injury to the hamstring, and patient is in rest. Patient is not complaining, but when you do some special test like bend knee test, the test is positive. Patient gives test for positive, and that way in that phase you can call you can call this patient is in phase three, and our rehab should start with the concentric training, and in that we can start rehabilitation accordingly.
Right, sir.
Yep.
So then we have a question from, again, Dr. Shalvi, what to look in modified Thomas test while assessing hamstrings?
Modified Thomas test, in that modified Thomas test we are stretching hamstring the affected leg. Basically, if you see, patient is able to complete the test without pain, the test is negative. But if you stretch your hamstring at hip, like as I have shown in that picture, like if he is if you are the test is positive when a patient complains pain during the testing. It is not basically if he can able to complete the test is negative, and he is bending his affected leg. Like in Thomas test, which Thomas test is for hip flexor tightness. We usually assess Thomas test for hip flexor tightness. So this is modified Thomas test for affected leg. And if patient stretches his hamstring at hip, it starts paining. He didn't complete the test. So that is the positive modified Thomas test. Positive sign of a modified Thomas test.
Thank you, sir. So, I think we'll see one or two more last questions, sir. Dr. Jayani and Dr. Nabisha. So, Dr. Jayani has asked, initial acute phases of hamstring strain, what is phase one? What protocol would you suggest the best according to research perspective?
Yeah, ma'am. In acute phase, basically initial acute phase, as I have mentioned, our first line of action for first 72 hours is like police protocol, like pressure, icing, compression, elevation has to be there for first 72 hours, and pain relieving modality mostly. Like our goal should be towards giving relief from pain. So for that, anything you can, the choice of treatment will be yours. But there are a lot of options available nowadays for pain relief. You can go with local ultrasound, you can go with local TENS therapy, you can go with IFP, you can go with laser, you can go with because as it is a pinpoint injury, laser will be again will be helpful. You can go with EMF. There are a lot of options available nowadays for pain free, like in acute phase modality to control pain. And we can start with isometric training, as I have mentioned in my rehabilitation protocol in acute phase. The early you start isometric exercise, the most you can maintain the properties of rest of like non-injured muscle. So that way we can start our treatment with, and of course pain-free range of motion also we can start. So that's how our rehabilitation program, and the reference is like Hamstring Rehab Protocol, Journal of Athletes for this.
So basically, as per that protocol, in phase one, you start isometric, phase two, concentric hamstring exercises, phase three, eccentric, phase four, complete return to sport training.
Yes, yes.
Understood. So because Nabisha ma'am asks the same question, is there any protocol like first we have to start only with eccentric, then followed by concentric? I think that answers the question, Nabisha ma'am. You have to
Actually,
go phase by phase.
Lavisha ma'am, actually there is it is just a protocol, ma'am. It will differ according to patient. Basically, if patient is with minimum, it is not always that patient will come with maximum pain to you. So if patient is not complaining much pain, but you are suspecting hamstring injury, you can start concentric strengthening directly to the patient. And if in concentric training also patient is not complaining much pain, you can straight away progress towards this if you tolerate. So it is subject. It is just a reference. The protocol is just for your reference. You can modify it according to patient. Basically, in what phase patient is coming to you, what all are his complaints are, how his mechanism of injury is. So that all factors are important in designing his rehabilitation program. So this is just a guideline, like we have to think this way. But while designing protocol, you need to assess patient thoroughly, and then only modify the protocol as per the patient's needs.
So some of the research also has talks about one of the criteria being, especially in the late phase of hamstring rehabilitation, that when you are loading the hamstring eccentrically, or you have started basic sports, basic agility drills and all, you have a 24-hour pain free window. If after 24 hours the patient does not complain of pain, they are good to go for the next phase. Otherwise you have to keep staying in that previous phase of exercises until they are pain free. That 24 hours window, is that valid, sir? Is that something that the physios you might want
Absolutely,
to look at?
absolutely, ma'am. That the 24-hour window, like, is one of the criteria for progressing towards next phase. The other criteria is patient is completely pain free and can able to do small drills of exercises without pain is again the next criteria for progressing towards next phase.
Right, sir. So even if they are able to do concentric, doesn't necessarily mean they should be still put here unless the pain has reasonably come down. Right, sir. I think if we have, do we have any other questions? Is hamstring sprain common in non-athletes also, sir?
It is very common. Basically, it is common in basically cramping. Hamstring cramps are very common. In hamstring cramp, there are chances of post cramp sprains. Are like we like I have seen many cases of post cramp. Like there was a severe cramp in my hamstring, and after that it started paining. So I treat those patients with this protocol, and maybe not go with them for eccentric training, because eccentric training will be too much for them because they all are middle-aged female. So definitely yes, non-athlete may hamstring is also common, and there are enthusiasts, sports enthusiasts. Sometimes like there are few people like marathon में जाना है, marathon करना है, and they go once in a while and they get injured. That also we get that sort of patients also. So it is common in non-athletes also. So, but the rehabilitation program, you need to, while designing rehabilitation program, you need to take one thing you need to take into consideration is the physical status of the patient. Like if he is an athlete, then only go for athlete rehabilitation. If he is a senior citizen, like one of the participant asked about TKR patient, those patients are very senior. They are old age patients, so beware while for going eccentric training with them. Just a concentric resisted training will be helpful to them. So that way we need to modify our program on patient base, like patient according to patient.
Right, sir. I think with that, let us now close the session because it's already past 4 p.m. Once again, thank you all so much for participating with us, for gracing the event. Thank you, Dr. Sagar, especially for putting in so many hours of effort. And I know it was a lot of back and forth with our team to put the PPT together, to put the curriculum, make it accurate, make it easy for everybody to, understand, make it palatable so they can implement in clinic very easily. So this is actually with, like sir was saying, that we can share the list of research papers, but this is research plus that clinical practice that Dr. Sagar has been implementing and seeing in his own patient cases over the past 20-21 years, that actually has been developed into this webinar for all of you. So I hope all of you were able to learn and take something new away today from Sagar sir. Thank you all so much with this. Any feedback questions, please do scan this QR code or leave a comment with our team, and we will try to make whatever your queries and doubts are. We'll try to help you get it resolved with Sagar sir. Thank you all participants so much, and we will be coming up with more webinars. So please do keep an eye out for those. Thank you, sir. Thank you so much for all the time and effort. Thank you, participants. I think we can all now log off.